They were named after the first two letters of the surname of the patient it was first described in. And I think it probably breaches patient confidentiality to tell you those names. Auntie Rowe was named after Patrice Robert, I think. There's a long list of the other patients these have been named after. Auntie Jo 1 was named after John somebody or other, because the person that described it didn't realise in America they put the first name second and the second name first. But moving on. The antiphospholipid syndrome. So just to highlight the core features. Recurrent miscarriages, often first trimester miscarriages. If you were to biopsy the placenta in someone who's had a miscarriage, you'd see thrombotic change. Arterial and venous thromboses, and the arterial thrombosis is important. Not many conditions cause both arterial and venous events. So early MI is a feature of the antiphospholipid syndrome. Migraines, and people with the antiphospholipid syndrome will often admit to this when you start questioning them. Epilepsy is more common in these patients, and thrombocytopenia. And this is important because sometimes the MRCP questions will offer you thrombocytopenia, and you may be thinking, are they trying to sell this as lupus? But actually, thrombocytopenia is a feature of primary antiphospholipid syndrome in the absence of any other features associated with lupus. We've already mentioned the paradoxical elevation of APTT. Rowe and Lahr, I'll just mention a little bit more, because these have a huge importance from implications in terms of planning a pregnancy, because the presence of these antibodies in the mother confers a risk to the fetus. It confers a risk during the pregnancy of fetal hydrops and potentially intrauterine death, and after birth of neonatal heart block, which can be irreversible. And because of that, mothers need to be counselled about what exactly the risks are, and there are potentially some therapies during the pregnancy that might have an effect on reducing that risk. Question 6. An 18-year-old Asian female is referred to the hospital by a GP following some abnormal blood tests. On questioning, there's a 3-month history of aching joints and fatigue, and over recent months she's also been suffering from thinning of her hair. On examination, her blood pressure is 90/50, with muffled heart sounds and elevated neck veins. I think that's Beck's triad, isn't it? Chest radiograph demonstrates cardiomegaly. This is sort of fitting together. Laboratory investigations are shown below. She's anemic, quite profoundly anemic, 6.5, low white cell count, lowish platelet count, normal CRP. I'm sort of expecting the CRP to... ESR is quite high though, isn't it? That's quite a difference. You'd normally expect CRP and ESR to go together. Although there's one example, one condition when they don't, and this might be this one. And the urinalysis, 2+ protein, but nothing really else on the left-hand side there to write home about. So which two of the following investigations are least appropriate? I'm not sure I like these two from many questions, but they do allow me to talk about a number of things that you would or would not do in this patient. Have a look through them, and I'll give you a moment. So the story here, and I've shown you a picture of Dr. Gregory House, our famous Hugh Laurie, partly because when he ever talks about cases, he always says, it's never lupus. And which can't always be true, because I see quite a lot of patients with lupus in clinic, but this is a fairly classic case. A young female, joint pains, hair loss, pericardial effusion, anemia, leukopenia, proteinuria. This all sounds very much like someone who's presenting with systemic lupus erythematosus. So the answer here is H and I. So the autoantibody profile, of course, you're going to do an autoantibody profile, and someone presenting with leukopenia and these sorts of features, you're definitely going to do blood cultures. She's anemic, she's slightly thrombocytopenic, she's going to get a bone marrow examination probably, isn't she? We're thinking lupus, so complement measurements seem like a good idea. She's got a pericardial effusion, so an echocardiogram's not going to go wrong. And yes, HIV tests, definitely need to exclude that. And in people with lupus, a huge amount of the mortality relates to renal disease, and she had proteinuria, so a renal biopsy is indicated here. Short-Synaptin test? I don't think that fits. They're selling it out because she had low blood pressure, but actually it doesn't fit at all with any of the other features. So Short-Synaptin test, Addison's disease, I'd expect the potassium to be high. Hers was on the low side, if anything. And white cell ascorbate? Well, that's a test for scurvy. And from experience, I can tell you this generally has to be sent to a lab a long way away. The nearest one to me is Newport, and it costs quite a lot of money because the sample has to be sent at -70 to get there. And for the most part, you can just treat people for vitamin C, so we don't tend to screen for that anymore. So SLE and membership. Look for the anemia, and anemia tends to be an extravascular autoimmune hemolysis. So rather than the intravascular people, extravascular hemolysis, splenomegaly, Coombs positive, the blood film would show spherocytes. Just to have in your mind the intravascular hemolysis, for example, people with MAHA or TTP, those people present with the schistocytes and fragmented red cells on the blood film and a low haptoglobin and a negative Coombs test. The serositis of lupus, well, the most obvious things to see are pericardial and pleural effusions, although in practice we see a lot of people who present with vague abdominal pains get admitted under the surgeons and no cause is found. That's not uncommon in people with SLE. And like I've said, the renal disease is what's associated with most mortality, so there's a low threshold to investigate people with renal disease, either proteinuria or climbing blood pressure. So these are some rashes of people with SLE. This is an artistic drawing, which I'm quite impressed as an artistic drawing from the NIH, showing you the butterfly rash of lupus. And it highlights something particularly important, and that's the fact this rash spreads across the nasal bridge. And that's different to, for example, the rash of, I've just forgotten the name of the condition. Hold on. No, it's gone. I'm going to start from this slide again.
Okay. Do you want to stop it?
No, you can carry on.
Okay.
Apologise about that.
No, it's all good.
So I'm going to show you some photos of rashes in SLE now. This first photograph, actually it's not a photograph, it's an artistic representation, courtesy of the NIH, quite a good artistic representation I think, of the butterfly rash of lupus. And I want you to notice the way the rash spreads and involves the nasal bridge. Compare that to, for example, the rash of rosacea, which tends to spare the nasal bridge. There you go, I've highlighted it for you. This next photo, this is a rash of someone who's got discoid lupus. This is where the rash, this is occurring in the hairline, so it's most prominent here, will cause scarring. There's not many things that cause scarring alopecia. SLE should be top of your list for membership exams. This is someone who's got more diffuse alopecia, and actually this is more common in SLE, to get what we often refer to as lupus hair, where the hair just starts to thin out. And it does recover actually with treatment. This doesn't scar. And this, what we've already seen a photograph in someone with the antiphospholipid syndrome, this is livedo reticularis, described as often a brownish, net-like rash affecting the limbs. It can be very marked, it can come and go. Patients often find it's quite disfiguring in terms of if they want to go out into the sunlight, which of course patients with lupus often don't want to do because the rashes tend to get worse in sunlight. Livedo reticularis isn't unique to lupus, and although I've mentioned in antiphospholipid syndrome and in lupus, it can be seen in other autoimmune diseases as well. Question 7. A 35-year-old female presents with difficulty walking and joint pains. Her symptoms started 12 months ago. Pain and stiffness in her hands. She's recently been on holiday to Turkey, and since returning has come back weak and noticed a rash on her face. Just pausing there. Turkey, what are we thinking about there? There's all sorts of infections there. Returning traveller, thinking malaria, maybe? Except she's got a rash, and it never causes a rash, does it? Let's read on. Examination reveals a butterfly facial rash. Her hands have rough, thickened skin, and they're bilateral knee effusions. Muscle strength is reduced throughout, but reflexes are normal. Blood tests reveal elevated inflammatory markers. Her CK is 1023, and she has a moderate anemia. This is an X-ray of the patient's hands. Have a close look at this. What is the diagnosis? A. SLE, B. Rheumatoid arthritis, C. Behçet syndrome, D. dermatomyositis, or E. Mixed connective tissue disease. I'll give you a moment to think about those. So when you're thinking about this, well, Actually, this patient's presented with symptoms that seem to fit into several of these. SLE, rheumatoid... SLE, well, the rash described sounds like SLE, a butterfly rash. Look at that X-ray again. If you look closely here, at the right hand, at the metacarpophalangeal joint, the second metacarpophalangeal joint, so the knuckle of the index finger, there's an erosion. The raised CK, you wonder about dermatomyositis. Behçet's, that's a bit of a red herring. They may be throwing that at you because she's been to Turkey, although of course it's not visiting Turkey that puts you at risk of Behçet's. The answer here is mixed connective tissue disease. Another name for this would be overlap syndrome. And this characterises patients who present with often a combination of features that overlap across several of these autoimmune diseases. Lupus, rheumatoid, myositis or polymyositis, dermatomyositis, and sometimes scleroderma. And the characteristic feature of mixed connective tissue disease is the combination of an antibody profile which includes a positive anti-ribonucleic protein antibody, the RNP antibody, which is pathognomic for this condition, and the presence of this pattern called mechanics hands, where the hands look fissured, dry, hyperkeratotic, as you can see in the pictures here. Question 8, last question. A 49-year-old female has been complaining of increased breathlessness on exertion. Clinical examination reveals distension of the neck veins and a left parasternal heave. Chest auscultation is clear. She also has tightening of the skin over her fingers and is unable to make a complete fist. Her face has multiple telangiectasia apparent. Which one of the following investigations will confirm the diagnosis? A. Bronchoalveolar lavage. B. Echocardiography. C. Flow volume loops. D. Lung function tests with diffusion studies. Or E. A right heart catheterization. The answer here is E. Right heart catheterization. So let's just think about what we've presented here. This is a 49-year-old female who's complained of, well, exertional breathlessness. Examination reveals distended neck veins. That sounds like a code for a raised JVP. And a parasternal heave. That suggests right ventricular hypertrophy. This sounds like pulmonary hypertension. Couple that with the tightening of the skin, sclerodactyly. This is scleroderma by the sounds of it, in association with pulmonary arterial hypertension. The investigations for pulmonary artery hypertension, well, first you probably would do an echocardiogram, but that can be normal. An echocardiogram isn't going to confirm the diagnosis. The test here that will confirm pulmonary artery hypertension is a right heart catheter. Which is the screening test for pulmonary artery disease? Well, even then you'd be hard pushed to say echocardiography, because the sensitivity and specificity of echocardiography to study the right heart pressures is low. So what do you need to know about pulmonary artery hypertension? Well, primary pulmonary artery hypertension, suspect that in a young patient, a young girl maybe with a history of asthma that's non-responsive to treatment. And they may describe to you the patterns of right ventricular strain. So perhaps there'll be a pansystolic murmur at the left sternal edge, accentuated by inspiration. That's the murmur of tricuspid regurgitation. Maybe elevated JVP, maybe a left parasternal heave. Secondary pulmonary artery hypertension now is actually more common. And secondary, as in secondary to HIV, chronic thromboembolic disease, so chronic pulmonary emboli, and beware COPD in there as well, and scleroderma, and that's the likely pattern here. And in terms of scleroderma, it's the limited pattern of scleroderma that you particularly watch out for lung involvement with. So part B to this question. This same patient presents to the emergency department unconscious. Her blood pressure, 240 over 165. And on examination, she's got papilledema. Laboratory investigations reveal acute renal failure. Which one of the following medications should you use to control her blood pressure? They've offered you atenolol, bendrofluozide, diltiazem, isosorbide dinitrate infusion, sublingual captopril. So the answer here is sublingual captopril. And this is because the renal disease here is probably a scleroderma renal crisis. And the evidence is that many other treatments that you try will fail to work. Nitrate infusions, for example, are often unsuccessful in people with a scleroderma renal crisis. And the treatment of choice should be ACE inhibition. In someone who's unconscious, sublingual Captopril represents a sensible option. Question 8c. In this same patient, what would her renal biopsy show? Crescentic glomerulonephritis, Kimmelstein-Wilson lesions, linear IgA deposition, mesangiocapillary glomerulonephritis, thrombotic microangiopathy. So this comes down to remembering what is the renal pathology in scleroderma. The answer here is E. Scleroderma causes renovascular disease, and actually the glomerulus itself is normal. When we talk about crescentic glomerulonephritis, we talk about ANCA-associated vasculitis, Wegener's granulomatosis, Sjögren-Strauss syndrome. In scleroderma, there's no inflammatory process going on at all. The CRP is usually normal. It's a thrombotic microangiopathy that occurs. Just to mention these other conditions, Kimmelstein-Wilson lesions, that's the hallmark of diabetes. Linear IgA deposition disease, that's Berger's disease. That's that nephropathy that typically presents in young, healthy people with episodes of synpharyngitic hematuria, usually painless hematuria, although they sometimes get some loin pain. Slightly more common in people with celiac disease, slightly more common in people of Chinese descent. Around 20% of those people get end-stage renal failure by 20 years. I'm sharing a little bit of nephrology in case you're getting dulled by the rheumatology. Mesangiocapillary glomerulonephritis, I've mentioned briefly already. So, scleroderma, just to finish with. There's two broad types of scleroderma, although they can overlap to some extent. People with limited disease, and by that I mean the skin disease is limited predominantly to the hands and feet and face. And this groups in the people that we used to describe with CREST. So that's the calcinosis, Raynaud's, esophageal motility problems, sclerodactyly and telangiectasia. And these people are slightly more prone to lung involvement, although can certainly get renal involvement. And people with diffuse disease, who tend to have less calcinosis, although often still have Raynaud's phenomenon, and are very definitely prone to renal involvement. And people with diffuse disease, we tend to preemptively treat them with ACE inhibitors, which has been shown to reduce the frequency of scleroderma renal crises. All of these patients we do tend to screen for pulmonary artery hypertension on a yearly basis. And the antibodies associated with this disease? Well, actually around half the people won't have an antibody, but the two antibody patterns we see are anti-centromere antibodies and anti-topoisomerase. Topoisomerase antibodies were formerly called anti-SCL70, reflecting the first 70 patients with scleroderma they described them in. We now know that's an antibody against a particular intracellular enzyme, topoisomerase. Thank you for listening. That's the end of this part 2 lecture.